It's fairly uncommon to have colorectal diagnosis in someone under 50, but it's certainly possible. And the people who are younger often have a family history, but not always. But the median age is somewhere in their 60s and 70s. There are multiple causes for colorectal cancer that have been found over the years. One of the primary causes relates to family history. So patients who have a first-degree relative or multiple first-degree relatives have a higher risk of developing colorectal cancer over their lifetime. There are certain diseases that increase your risk of developing colon cancer. One in particular, or one category in particular, are the inflammatory bowel diseases like ulcerative colitis and Crohn's disease relatively increases one's risk of colorectal cancer. And then there are things that are more modifiable that can increase your risk that can relate to your risk of colorectal cancer. Those include obesity, increases one's risk of developing colorectal cancer. Physical activity decreases one's risk. Certain dietary things like diets high in red meat will increase one's risk of colorectal cancer. There are certain agents that help prevent colon cancer, like a daily aspirin use. Postmenopausal hormones decrease one's risk of colorectal cancer. They have other risks that have led them to be less popular these days, but they actually do also decrease risk of colorectal cancer. Vitamin D, so people who have higher levels of vitamin D have a lower risk of colorectal cancer. The first step when someone's diagnosed with colon cancer is we figure out has it spread anywhere, and that's part of the initial staging of colon cancer. So one will get a CAT scan often of someone's abdomen and pelvis and some imaging of their chest, and then determine has it spread anywhere outside of the colon or rectal area. And then if it hasn't spread anywhere at the time of surgery is where the rest of the staging occurs. So the pathologist will look at the specimen that's taken at the time of surgery and look how far it's gone through the bowel wall and whether there are any lymph nodes involved. There are 4 stages of colon cancer, stage 1 to 4. Stage 4 are people where it's spread outside the colon area. The most common areas of spread are the liver and the lungs. Stage 1 is the earliest stage of colon cancer where there are no lymph nodes involved. It hasn't spread outside the local colon or rectal area, and it hasn't gone very far through the bowel wall. Stage 2 disease are patients where it's gone a little bit more through the bowel wall, but no lymph nodes are involved, and again, no spread to other organs. And stage 3 disease is no spread to other organs, but it did involve some of the lymph nodes in the nearby area. The reason that this is most important when we treat patients is it determines what's the best treatment for patients. So most patients will still have some surgery to remove the primary lesion that's in their colon. For patients with stage 1 to 3 disease, surgery is the first step, and then some patients with stage 2 and most patients with stage 3 disease should get chemotherapy after for approximately 6 months. For patients where it's stage 4, where it's spread to other organs, there's a whole variety of different treatment schemas, and it really depends on the extent of the spread of the disease and how the patient's doing, how the patient's feeling at the time when they're diagnosed. Chemotherapy is used in 2 settings in colon cancer. First, for patients who don't have metastatic disease, and then patients who have metastatic disease. For the patients who don't have metastatic disease, it should be offered and commonly is offered for patients at least with stage 3 disease and some patients with stage 2 disease who have higher risk. Again, stage 3 disease patients, no spread outside the colon, but there are lymph nodes that are involved near the colon with the cancer. Stage 2, no lymph nodes were involved, no spread outside to outside organs, but a little deeper through the bowel wall. In those patients, we use chemotherapy for about 6 months to try to reduce the risk of recurrence. And there have been large randomized trials, particularly for stage 3 patients, where it's shown that it decreases the recurrence rate and improves overall survival. For patients with metastatic disease, there have been a lot of advances in the treatment in terms of chemotherapy, particularly over the past 10 years. Before 1998, there was a single drug FDA approved, 5-fluorouracil, for the treatment of colorectal cancer. Now there are 7 drugs in 5 different drug categories that are useful in the treatment of colorectal cancer. Back before 1998, the median survival with metastatic colorectal cancer was about a year. Now, with the use of multiple other agents that are helpful against the disease, the median survival is greater than 2 years. So there have definitely been advances, though there's clearly a long way to go in treating patients even with metastatic disease, where there's use of chemotherapy both to palliate symptoms, prolong life, and also to maintain good quality of life while people are getting treatment. So a colonoscopy is the best way to look to determine if someone has a problem in their colon. And people should get screened with colonoscopies. The current recommendations for the general society is to screen at age 50. There are some patients where we'd start screening earlier, depending if they have a family history or certain diseases that put them at higher risk. The issue of a colonoscopy is one has to prepare for a colonoscopy before the actual procedure. And that includes changing somewhat your diet for the several days before the colonoscopy, as well as doing a prep to clean out the bowels so that the person who does the endoscopy is able to see well the colon wall inside. And so the preparation in terms of food to eat before a colonoscopy does depend a little bit on the individual patient. So in general, you don't eat at least 12 and generally 24 hours prior to colonoscopy. One will turn to really just a liquid diet about 24 hours prior to colonoscopy. For some patients, particularly ones who've had a colonoscopy and haven't had as good of a preparation, those recommendations may extend even to a little bit longer time frame before the colonoscopy. There are certain dietary things like avoiding red things like red Jell-O and red foods to avoid a few days prior to the colonoscopy. And all these are described by the gastroenterologist or the gastroenterologist assistant before your colonoscopy to tell you how to change your diet and when to start preparing. The reoccurrence goes back to the staging. So the people who recur are the ones that didn't have evidence of metastatic disease at the time when they're diagnosed. So those are the people with stage 1, 2, and 3 disease. And then at some point later, it comes back, and comes back means that it's visible somewhere else in the body. The likelihood of it recurring inside the colon, the actual cancer that you initially are diagnosed, is actually extremely small. There is a risk of developing later colon cancers or other polyps, which is why people who already have colon cancer should have more frequent screening colonoscopies throughout their life. But the higher risk is it developing in another organ. And the reason that it recurs is thought to be that there were small cells or small pockets of cells that were already there at the time of diagnosis, but they weren't visible on any CAT scan or PET scan or MRI, and over time they grew. And that's the basis of why we give chemotherapy for certain patients after they have surgery for colon cancer, because theoretically that chemotherapy hopefully will kill those pockets of cells that are set up shop either in the liver or in the lungs and make it so that there's never a recurrence. Unfortunately, chemotherapy doesn't 100% guarantee that there won't be a recurrence, but particularly for stage 3 patients, there's large bodies of evidence that suggest that it does reduce that risk. Again, a colonoscopy is done to help screen for colon cancer, and the particular goal is to make sure there aren't polyps or certainly a cancer in the colon at the time. It's based on recommendations from your physician for screening purposes, or if there are particular symptoms that patients have, like rectal bleeding, that require them to get a colonoscopy. The way one prepares for it is first you get an appointment with a gastroenterologist. For the most part, a gastroenterologist or a surgeon will do a colonoscopy. There are some primary care physicians that do colonoscopies as well. And there's a preparation that's needed to cleanse your bowel. Now, depending on the age of the patient, other issues, if they've had issues with prior colonoscopies in terms of how well they were cleaned out, will determine exactly which preparation is used and when they have to stop eating and turn to a liquid-only diet prior to the colonoscopy. The preparation is done the night before a colonoscopy, and the next day one doesn't eat or drink anything. They go to the wherever they're having the endoscopy, and the endoscopy itself takes anywhere between about 20 minutes and 1 hour. The patients who are on aspirin or blood thinners need to stop those prior to a colonoscopy because the gastroenterologist or surgeon may take a biopsy if they see anything that they're concerned about and doesn't want to have bleeding. So if you're on aspirin or blood thinner, you need to make sure your gastroenterologist or surgeon knows that prior to a colonoscopy. At the time of the colonoscopy, they'll be able to look and see if they see anything abnormal and be able to give you that report if they see anything abnormal at the time of the colonoscopy. The if they do send any biopsies out, it usually takes anywhere between 3 and 7 days to have those results back to be able to report out. Patients need to come with someone to a colonoscopy because in addition to having you have a preparation the night before, at the time of the colonoscopy they'll give you some sedatives to help relax both yourself as well as your bowel to be able to do the colonoscopy adequately. And thus you can't drive home after it. The surgery for colorectal cancer is different between colon and rectal cancer. So starting with colon cancer, there's 2 types of surgery. There's an open surgery and there's a laparoscopic surgery. And there's actually been large studies that have shown that with a surgeon that's experienced in laparoscopic surgery, the outcomes can be equal. For either of them, the overall goal is to remove the cancer and remove several centimeters proximal, so before the cancer, and several centimeters distal, or beyond the cancer, in the colon, and then to reconnect the colon together. For the most part, people with colon cancer will be reconnected at the time of surgery. There are people who present where they've had their bowel obstructed and they may have a temporary colostomy, and later, several months later, the surgeon will then be able to reconnect. But for the most part, people are reconnected at the time of surgery to have normal bowel function again. For rectal cancer, the difference is because the rectum's in the pelvis, which is a more fixed structure, and there's a fair amount of muscles that control continence in there, the location of the rectal cancer depends on what type of surgery you have. So again, there are options to be either have an open or a laparoscopic surgery for rectal cancer, but patients where there's a fairly low rectal cancer right near the muscles that control continence, some of those patients are going to require a permanent colostomy. So a permanent colostomy is required for certain people with rectal cancer, but still most people with rectal cancer fortunately don't need a permanent colostomy. But it's better to actually have a permanent colostomy than to be incontinent and not have normal bowel function. The first thing to say is that for any individual person, it's impossible to pinpoint exactly why they got colon cancer. But we know about a variety of things that increase your risk or relatively can decrease your risk. And when you think about that, the ones that are modifiable, one can do to try to prevent their risk of colon cancer. The number one way to prevent colon cancer is to get screening. And again, there are recommendations to do screening at age 50 for the general population, and for some high-risk patients, we may start that a little earlier. The potential other causes of colon cancer include having a family history, and there are a variety of different schemas in terms of how important a family history is relative to one's individual risk of developing colon cancer. And if you have a family history either of colon cancer in an immediate relative or even colon polyps in immediate relatives, this is something to discuss with your physician because they may recommend starting screening earlier than age 50 for you. The modifiable risk factors, and when I say by modifiable, things that we can do to change our risk as well as related to the cause of colon cancer include obesity. So there's fairly good evidence that people who have higher body mass index have a relatively higher risk of colon cancer, and so avoidance of obesity and maintaining a healthy weight is important. Increasing level of physical activity decreases your risk of colon cancer, so being physically active over a lifetime helps reduce your risk of colon cancer. There are certain dietary factors that have been shown to be relatively related to the risk of developing colon cancer. The one that's probably the most important so far has been red meat, and so higher intakes of red meat increases one's risk of colon cancer. Doesn't mean you have to totally avoid red meat. In fact, having probably about 2 servings or less a week is probably acceptable. A lot of people think about fiber as related to their risk of colon cancer, and though early evidence suggested that fiber decreases your risk of colon cancer, more recent studies have essentially shown that the level of fiber that one takes in their diet does not relate to their risk of colon cancer. Colon and colorectal cancer. So colorectal cancer includes cancers both of the colon and the rectum. The colon is your large bowel. The rectum is the end of the large bowel. It traverses across your body from the left side to the right side. It's after your small intestine. And its main function is to help continue processing waste as well as actually reabsorb water in the food that you ate. About 150,000 people will develop a cancer in their colon or rectal a year in the United States. The reason for someone developing a cancer is that something changed in some of the lining cells of the colon that caused them to mutate, or some gene caused a little change where the cell's not acting like it normally started. And so that mutation over time can develop into a polyp. Polyps are precursors to colon cancer. Not all polyps become a cancer, but a fair portion will, which is again why screening colonoscopies are helpful, because if you remove a polyp before it becomes a cancer, then you prevent the patient from getting colorectal cancer. And over time, if a polyp becomes a cancer, then it has the potential to spread. So what we also know is that from the time one cell becomes abnormal in the colon to the time someone has a cancer is somewhere between 5 and 10 years. It doesn't mean that if you are diagnosed with colorectal cancer 5 years ago, if someone did a colonoscopy, they would necessarily see something. It's just an individual cell becoming abnormal, then becomes a polyp, and some polyps over time, over several years, then could develop to a cancer. But from the first change to the time you actually have a cancer is probably about 5 to 10 years.